right, I think we'll start with any audience questions. Oh, several way back there. Here. Right up there. Yes, several up there. Okay.
That's okay then.
Right up there, y'all.
I just want to make a comment about the number of missing zip codes in the survey. Some may know and some may not know. Zip codes didn't come into use until 1963. So I remember when they started using zip codes. So a lot of older people may not have had a zip code when they were a child.
Yes, please.
Thanks, Betsy.
Dr. Stites?
Yes, that's exactly right. When we were initially pilot testing, we ran into that issue. It's also because we're seeing people move to Philadelphia from all over the country as well, and zip codes can vary based on where people are, right? There's a lot of, one outstanding caveat is to put, like, this was done at the University of Pennsylvania. It's a certain demographic, right? As this rolls out into other locations, we're gonna have to see how it performs, and I expect there are differences. In terms of zip code, to help address that, there wasn't really a great alternative to go to, and the base rate was fairly low for those people who couldn't report that information. And so we built in a multi-tier system of asking about geography. So what country, what county, and what town, if they wanted to opt, just to try to get another approximation. Given how relatively small our cohort is compared to like the US population, we know we're still gonna have to aggregate above zip code anyway, so we'll see. Thank you for that, though, you're spot on.
I believe we have another question here from Dr. Wilkins.
Yes. Thanks so much for the focus here on the social and structural drivers. I can remember having a conversation with Dr. Morris a few years ago about adding them, so great to see that work go into action. I had a couple questions, perhaps starting with Dr. Stites. With your plans to do the repeat, I didn't see a plan to collect the demographic data again. And just wondering, as terminology continues to evolve, how people might change their self-identification, is there a reason that you're not collecting that? And then the next question is around the structural determinants. It wasn't clear to me what you're collecting that's actual structural determinants. I didn't see anything related to structural racism, environmental pollutants. I don't know if any of that is being included in some of the surveys that I may not be as familiar with. Thank you.
You're gonna have to help me out to retain both, all of that. Oh, okay, sorry. Those are excellent. Yeah, so one of the things that we don't have an answer to yet, but we're aware of, is we know we want to put measures in, we want to take measures out, we want to repeat measures, right? We want to use this as a living battery, like, you know, to coin a term, and so that we can help advance the science and what's understood about these factors. And so that said, it's still very alive in the decision-making process about how often we might repeat things, how often we might switch out a measure. And I think at this point we've actually changed since these slides went together, and we have some demographics that are being repeated. But again, we're back and forth, trying to figure out what's right for our participants and what's right for actually capturing the measurements.
And then the structural drivers, racism, environmental pollution, are you collecting that?
So most of what we're collecting, we have two ideas going on. One is, what can we learn from participants about their subjective experience? What can they tell us? That's the everyday discrimination scale, perceived stress scales. And then we're also gathering things like zip code and occupation, which is allowing us to then calculate what you're gonna call structural measures. So we can figure out where they're living and what type of exposures they have.
Dr. Zuelsdorff, do you have any response to Dr. Wilkins as well?
I'm not able to speak to the SS dyad, but I think the structural piece of your question really underlines our need to reach across disciplines and work not just within medical schools, but probably work with people in the social sciences and in policy. You know, they have differences in differences designs, all these things and we've got policies right now changing so fast that you know, I think we really need to be looking at what are the impacts on communities when policies change like this. I hope that we are always accompanying, you know, those kinds of measures, though, with actually also assuming that what happens in communities across the U.S. from us, maybe geographically, if we're part of the same community, but on the other coast, we're still impacted by watching this happen in real time, by watching discrimination and violence happen. So I do think it's an area where we really need to be working hard and working carefully.
I think we have one more question here. Dr. Jackson?
Hi, Jonathan Jackson from Mass General Hospital and Harvard. Are social determinants of health the same thing as social determinants of participation and retention? If they are not, should we be thinking about these topics differently?
I think, Megan, can you field that?
I think, I don't want to get this wrong, Dr. Jackson, I think there's a lot of overlap between the social conditions that produce health disparities and the social conditions that make it very difficult or unwise for communities to participate in research done in the same institutions that, as you pointed out, have been oppressive for most of the past and continue to be in many cases. There's probably places where they don't overlap.
It just creates a selection bias, and I'm wondering how you can address that.
I like to talk about selection bias. What do you mean?
Sorry, just to clarify, if social determinants of participation are the same as the social determinants of health, then how can you measure, how can you get sufficient variance in the social determinants of health if these are the same things that sort of prevent participation?
Oh yes, I have strong opinions on this. You do it by breaking down, by asking people what the barriers to participation are, and then breaking them down. Some of them it takes time, right? Like the ones that require relationship building, those are not going to come down immediately. The ones that look like, how burdensome is this protocol? How much time does it take? Do I have to go park in the downtown of a city at rush hour or during 9 to 5? Or do I have to answer the phone, at a particular time? These are things that our centers can do immediately, and I think that the minute we start breaking down barriers, then we start seeing more representative samples. Never perfect, right? And we always probably need to be assessing, who we actually are sampling. We don't even right now collect the data that would allow us to do that, though. So I think there's a long way to go, but I think that breaking barriers, you're going to see increased representativeness. That's what I would say about it. So selection bias is always going to be an issue, but we can start mitigating that. When it's worse, as you know, is when we're just letting people bang down our door and get in waiting lines to participate.
Thank you. I think since we have a nice chunk of time, I would like to pose a question to, yes, sure, go ahead, Shana. Yeah.
To add to Megan.
Speak into the microphone, online can't hear you.
Yes, can you hear me now? No, maybe. To add to Megan's response there, I think it would be great if some of the people in the first part of today's sessions partnered with the people in the later part of today's sessions to build some bridges, because I think it might take the collaboration of, bringing people in as well as helping get the measurement right and the participation right while they're in.
Well, Shana, I think you kind of bridged that because I wanted to bring that in myself. So thinking about Dr. Wilkins' question about terminology, especially in light of the social determinants of health and all of our guidance we've seen lately, could you speak to that dynamic role of terminology, especially in the language guides? And then what does that look like with input from communities?
Even though you're standing over here, I'm going to look this way into the mic.
Sure, yeah.
No. That's a great question. I think we're at a difficult time, exciting but challenging. We're rolling out these batteries and rolling out initiatives to enroll people into research and to increase that representation and the diversity. Because we want to do this on a wide scale while also engaging a wide range of differing communities. Like with the language guide, we're trying to provide some general guidance and good practices in terms of how to engage language with communities, but we can't come out with direct, we can't dictate the language that's used and the exact language or the questions that need to be used in those communities. Much like this battery reporting the results at UPenn, that's what we found. As this happens in other ADRCs with other populations, things are going to need to change, be adapted to meet the needs of those populations. Marissa, do you have anything to add to that?
I agree.
Megan? Uh-huh.
I don't have a lot to add. I'll just say that I'm a really strong believer that our conceptual models that inform our analytic models, we need to describe them. They need to be conceived well. They need to be conceived from a lens that incorporates equity and the equity process all the time. And then we need to describe them carefully so that they can be understood and they can be mirrored by all of the people who are watching our presentations, who are reading our papers, who we're training in the classroom and in the clinical setting. So I think that measuring the right data, making sure that you are always being fully transparent in your methods about why you chose to control for race or why you chose to control for this variable or this variable or this variable. These are really important ways to communicate with sort of future researchers. And for me, that's the tie between language that promotes equitable research and models and data that promote equitable research.
Thank you. I think we have a question here.
Thank you. Hi, everyone. I'm Jessica Mazurski from the WashU Night ADRC. So slightly different tangent I'm going on here, but I have an interest in return of results. And I have a question that I've thought a little bit about, and I'm curious what others think here. Is there a way to return this data to participants? And if so, how would we do it without causing harm? And I'll just tell you the reason I'm thinking is it takes, I think, about 30 minutes. And I imagine, I don't know if anyone's encountered, participants might want to know what we're doing with that data, and we have an obligation to tell them and possibly report what we find. And I'm just curious if anyone's thought about how we might do that sensitively.
So I think you're asking more than where I'm going to go. But to start with, we do have some statements. I'm a firm believer of you have to tell people why you're asking them for data. And so we do have statements within our survey that's telling people why we're collecting it or the purpose there. So that's like a starting, it has nothing to do with return of data, but as a starting point, that transparency issue that has come up in earlier sessions. I struggled a little bit hearing like returning this information could create harm. I'm not sure, because they're giving it to us, right? Unless we sort of twist it around in a way, I'm not sure the harm in giving it back to them.
I'm thinking harm like you've shown me what I already know and shown me that there's structural racism, and what are you going to do to make it better? Or I'm seeing the data between my white participants and non-white participants, and it looks exactly like I think it looks, actually. We do way worse. What are you doing now? Or, you know, kind of creating a sense of cynicism in some ways among some people.
So that last point has definitely come up in the literature and in conversations, right? When you start to create models that then are about risk and determination, you start this sort of spiral. But in other ways, telling people what they know is there is actually quite validating, right? As a general rule, like maybe some of the friction goes to was brought up in content in earlier sessions in terms of how researchers manage this, right? I was thinking, we were looking at some of the data from our battery. I have a student who's going to present some data from the everyday discrimination scale in an upcoming conference. And we're seeing this within this fairly homogeneous population, this very wide range of experiences around discrimination. And to recognize that those are our research participants, they're the people who are volunteering that we're interacting with, and how do we do that in a way that doesn't compound those prior experiences and acknowledges them. And I'm not sure that our research community is there and fully ready to meet that yet. And so maybe that's getting at some of the question that you're asking there, is like, how do we help the research community better meet the participants where they are?
Thank you, Shana. I would like to hear from Marissa on that, especially being so community-facing, patient-facing. What is your perspective on the question?
So I agree, Jessica, and I for real this time I agree. But do you mean maybe giving them the results of the cohort, like say, you know, because they know what kind of discrimination they face, et cetera. Actually, that's interesting because I have had participants ask, like, why are we doing this? And so when that happens, I always take a call myself, and we'll kind of just talk about the importance of looking at the whole picture when we're looking at Alzheimer's disease. And so maybe it's possible for us to return some of this data. Maybe. I know they're interested.
I was just curious, so thank you.
Other audience questions? Trying to scan. Oh, great, right here.
Just related to that, this wasn't my original question, but working with indigenous folks, so I'm from New Mexico. Sorry, Jessica Richardson, New Mexico. I wouldn't automatically assume that because they're giving information that they want the information back. And so I would just be very careful about that assumption. And I see you now. Because we've definitely had those conversations where if we finally get some people, and of course it has to be worked out, you know, with the tribal leadership, where they are willing to give, for example, some CSF or a scan, they don't necessarily want that information back because they have other indigenous ways of knowing that are different from ours. There are other terms that they don't want introduced or don't want to be talked about in their community because it could bring it into existence. So there's lots of other things that go into that. So I just wouldn't necessarily assume that.
And I'll clarify real fast. We don't just give them out, like as a group. There's a very systematic process the way we are giving out research results, and they have to agree. And so when the people say no, we don't.
Yeah, and I hear that. I just think one of the comments was like, well, they're giving us the information, so I just wouldn't assume that they want it back. And that readiness research is definitely what you're referring to as well. My question was actually, have you accidentally run into information about structural or social determinants of health related to people with disabilities, or are they just completely excluded from these studies?
Shana, you want to pop in?
I apologize because I meant to say this during my talk. You had brought disabilities up in an earlier session, and so the framework paper that I referenced during my talk actually does include disabilities, so I apologize for not making a point of that earlier. And we include some questions around learning disabilities, physical limitations in our current battery. There's more, of course, that we could add there, but at least as a starting place, we have some.
It's wide open. Wide open area for research. Yes.
Megan, any input there?
Yeah, so I will say the Stress and Resilience in Dementia study uses pencil and paper questionnaires to pair with all of the cognitive and biomarker data and so on collected by our ADRC in Wisconsin. And so I end up in the data processing process seeing a lot of participants who will scribble in answers, and I don't want to give too many details because it's not very many participants, but absolutely I have participants who are noting the intersections between adversity and disability, and I'm hoping that that research area really grows now that there's funding for it, it's in the NIH's language, and there's a lot of momentum building. Thanks for the question.
That is
We have
another,
one.
I'm sorry.
No, go ahead.
We did run into some of that with the temporality of some of the changing terms in our piloting. It's really stood out around like learning disabilities, right? People informally noting that they're like, yeah, no, in hindsight, this is probably it. But those mechanisms weren't in place for the diagnosis or anything at that time. And so that's something to be aware of. And then the second point I just wanted to underscore is we do have an issue, this intersection between really low base rates and potentially a desire for transparency in the data. I know I have a tendency, part of that background in GIS, is to always try to like be concerned for the base rates, right, and protecting people's identities unless they're, you know, fully consenting to have that information revealed. But there's clearly some work to be done right there.
And we have one here with Dr. Jackson and one here with Dr. Cohen. So we'll do you, Jonathan, and you, Annie. Okay.
Okay. Thank you. So one of the recurring themes I heard across all three talks was the concern about data burden. The idea is that there are more social and structural determinants that are important than we have time to measure. And so, you know, Megan, I saw that you had a really good idea about specific centers, adding specific modules. But is there maybe a plan in the works, or is there any discussion or conversation around either passive data collection techniques, data purchasing from like maybe a tech giant, or partnerships and research, or working with, you know, maybe at a slight level of data aggregation, like market analytic firms? You know, is there a way of maybe reducing this burden from the level of the individual, but still getting really high quality data that would be really important as we characterize these social determinants?
I'm really curious what my co-panelists have to say, but because you said my name, I'll start out with this. That is a really interesting idea that I hadn't thought about before, actually. I will say part of the reason I haven't thought about it is because I use a linked study approach where actually I have a separate consent form and I pay participants quite a bit extra, and then my entire protocol is designed to be as low burden as possible. They have to spit in a tube because we look at cortisol in their saliva, but they can do it all from home, and they can actually send it back via regular USPS, and we try to make it really easy. And actually, so far the participants that I've talked to on the phone have expressed a lot of satisfaction with participating in the protocol, said that it was not difficult. We did have one point where, I think it was during the pandemic, where it was expressed to us that the payment, which I think was about $20 less than it is now, that it felt not sufficient, that they were feeling really overwhelmed, so I upped it. And after that, we had great feedback about it. That said, yes, burden is an issue. I think we have to toe a line between saying that this data is really important to get from everybody else, but this population we don't want to burden, so we're going to get less data, and it's going to be maybe a little less good, right? Because everybody deserves, if we decide that some kind of data is the gold standard, then we need to make that level of data accessible. But you're gonna have to talk more because it's a really fascinating idea.
Shana, Marissa?
Yeah, if I can remember my points, I think I have three. One is some of that work is going on. It's not necessarily mine, but it's happening, right, to speak to, but it is happening out there. It's usually really specific in its modeling and its assumptions and what it's targeting, which is a little different than what we're trying to do here, where we're not always exactly sure what we're looking for, or we have some information, but we're moving into new information. The online panels themselves are actually still struggling. They started struggling during the pandemic, and they're struggling a lot right now. So I would question, like away from wearables and those sort of higher tech analytics, that I'm not sure the quality of data that's going to come out of some of the panels, given how difficult that is. And then the third I would just raise is like when you get into the who, you know, if we were to dream about really getting to some of the people we'd like to hear from, some of the people that are experiencing the greatest burden, I don't know that we're going to get them through those channels.
I believe we have one more question here in the front row.
Hi, Annie Cohen from the University of Pittsburgh. So I actually have a question about the people who are sort of largely left behind in a lot of this. We work a lot with adults with Down syndrome who are aging into dementia, and then adults with autism who are aging into, or autistic adults who we don't know what they're aging into just yet because there hasn't been any work on them. And one of the questions that I frequently have, and that I think we struggle with as people move into more severity in Alzheimer's disease as well, is how do we collect these measures in individuals who have intellectual disabilities or more severe dementia, so we can understand the intersection between a disability like Down syndrome or neurodiversity like autism and the social determinants of health and how that affects outcomes. I know it's a really hard question, but I would love to hear y'all's take on it.
I'm sure it would complicate matters even more so. I think it's difficult to possibly recruit participants to find out, but I don't know what the future would necessarily look like for that group.
Shana?
So that's a great question. I like measurement if you can't tell. It's exciting. So there are data systems that those individuals and their families interact with that could give us some of the information we're looking for. And so it would be routinely collected data that would be novel in ADRD. That's one avenue I would go to. And then the second one is an area I'm very interested in that is exploring different ways of collecting data. And then there's, of course, like what is self-report versus what are some of the other technological interfaces that are coming along, and how could we use those, as well as, of course, like body metrics and such. And then the third one is one we're familiar with in ADRD, is always the study informant, which, right, in some cases, that, like you're talking about children with developmental disabilities who are now aging, you may have some informants that are truly like lifelong informants, but still those issues, I'd be more interested in the first two if we could do it.
Megan?
I don't have a lot to add to that, but I will say that this is an area that I see is there's so much room for development, and I hope it's a huge focus in terms of projects that we see in the next couple of years, which is designing assessments that are able to that work directly with a participant who's living with dementia or living with autism or living with Down syndrome, and assessing their needs as they communicate them, right? So my colleague that you know, Dr. Gilmore-Bukowski, is thinking a lot about this for patients living with dementia, and how do we center what they perceive and experience. It just seems like it is wide open, and I hope it's an area of focus. I'm sorry I don't have any answers, but I'm excited about your question and the interest in that.
All right, well, thank everyone for a lively discussion, but we are at time, so however you want to handle it. We have a comment here.
I was just going to encourage you to reach out to your friendly neighborhood speech-language pathologist or speech and hearing sciences department or communication sciences and disorders department. You will find collaborators that can help move from one silo to another to answer these questions. So if you need help finding them, let me know.
Great. Thank you.